Good morning everyone and welcome to another Insight APSAD webinar. My name's Jim Hunt, I'm one of the nurse educators here. First of all, I'd like to kick off with an acknowledgement of the traditional owners and custodians of the land on which we're meeting today, and I'd like to pay our respects to elders past, present and emerging, and I'd like to extend that welcome and respect to any Aboriginal or Torres Strait Islanders that might be joining us in webinar land or in the room today. So thank you and welcome. Today we've got a couple of colleagues that I know from QuIHN, which is an organisation that I'll let them tell you about, but they're going to be talking about the topic of hepatitis C. Now, I've been in the alcohol and other drug field for probably longer than I care to remember. I think we're getting up for about 27 years. And so I remember the days when I've told far too many injecting drug users in the UK that they have hepatitis C. And back in those days, it didn't have to be a death sentence, but essentially that's quite often how it ended up for them. So it's kind of exciting for me to have Mary Fenech and Gary Keogh come along and tell us just how things have changed and what's going on currently. So I'd like to welcome Mary and Gary up to the stage. Thank you.
I'd like to thank you all for inviting Mary and myself to come and talk today. Mary's a nurse practitioner with our organisation, and I've recently become clinical nurse consultant for the organisation. Today we want to talk about the treatment of chronic hepatitis C in substance use population. And even though we've been treating for the last 3.5 years with the new directly acting antiviral medications, and we had a lot of uptake in the beginning, unfortunately, the treatment uptake has dropped quite substantially over the last part of last year and this year, and I think it's quite a reminder today that we really need to look for those clients, especially those that are harder to find or do have challenges, to actually try and get them into treatment when they're ready to get into treatment. We have some acknowledgements. Mary's put hers up there. Mine are basically the same, and I'm also on the Merck Sharp and Dome advisory board for opioid substitution therapy. So today, and Mary did these slides so I can see where her passion was when she was writing them, to raise awareness and promote the treatment of hepatitis C, and I think that's the primary thing we want to do today, is get as many people who are ready to treated. Provide an update of the current treatment for hepatitis C to clarify the processes of eligibility for treatment, and I think we're exceptionally lucky in this country that everyone can be treated for hepatitis C. Discuss barriers for treatment, highlight resources and facilitate your treatment knowledge, and then you've got a chance today to have some questions if you need to. Empower you to identify and treat your own patients with hepatitis C, and particularly in a drug-using community. So this is a bit of self-promotion. Most people in this audience would have heard about QuIHN, but for those of you who aren't familiar with QuIHN, it's the Queensland Injectors Health Network. And it's a statewide not-for-profit, non-government organisation which looks after the health needs of those with illicit drugs. And I think we're outgrowing our name to some extent, because I see as much alcohol and prescription medication as I do illicit drugs these days. But we're there basically for anyone who has a substance issue that's concerning them. We've been around for about 15 years. And we came about from an amalgamation of QuIHN, Skiva and Junes. And QuIHN is basically there to try and give a holistic approach to looking after people with drug and alcohol issues. So as you can see, we're starting to grow. We're up and down the seaboard of Australia, I hope, of Queensland at the moment. And the services we provide from each site is dependent obviously on funding and also the local needs for each of the areas. So we've got counselling up in Cairns. For the most of those sites, we do what's called treatment and management program, which is our hepatitis C program. So anytime you can see TMP there, that's hepatitis C treatment. Most of our sites also have primary NSPs. We've got a secondary one at Southport. And we've also got harm reduction officers in most of our sites. So you can see that we are trying to give that holistic approach to care. So I think I've already said this a little bit. We've got a needle exchange program, peer support, and we're starting to employ peer workers more, and I think we're having great success with that. It's amazing that, you know, I've worked with vulnerable clients for the last 30 odd years, but when you've got a peer who's actually gone through treatment, who's used drugs, which I've done neither, they talk a language that I can't talk to the client. And there is a real understanding and a real empathy between the client and the peer worker. We do workforce education. One of the proudest things I think about QuIHN is that we have a GP practice that looks after a lot of vulnerable clients over here at Bowen Hills. And even though it's a general practice because we need to pay the bills, but it's also for gay, lesbian, transgender, for people who use drugs, for anyone who and for sex workers, anyone who identifies as a vulnerable population. We're there. Also do counselling, drug and alcohol, dual diagnosis, and I think the big schism between with our clients is that mental health doesn't see the importance of drug and alcohol doesn't see the importance of mental health. We at QuIHN try and marry the two together and realise that you can't separate them for a client's care. We also do some group work, and the other thing we put out 3 times a year is a Tracks magazine, which has contributions from the staff, but also from the peers, from the using population, which is a great way. I mean, look, we know that our clients talk to each other and communicate, and actually will listen to what other people in their community are actually saying. And that's a great way in print to actually get that out. So to the treatment and management program, look, for some people in the community that are quite functional, you give them the pill, you say come back in 8 to 12 weeks and all's good. But obviously, our clients have their own barriers and they have their own problems that they need to get over to actually, for them to remain adherent to their medications. So we work collaboratively, and I say that quite a bit, but we've got harm reduction workers, we've got peer workers. So when anyone is being worked up for treatment, it's quite an extensive assessment from both a psychosocial and a physical and an emotional level. And it's important to see those barriers, especially for a client going into treatment, because we really do want them to have the best chance of success when they're being treated for the first time. So who's out there at the moment? This is data that came from early last year. So we know that those that have Hep C are easily treatable. We know that most of the cirrhotic clients, even though there are some around, most of them have been treated by the tertiary sector. So what you've got coming into your practice is usually someone who hasn't been exposed to the DAA therapy, the hepatitis C therapy, and are easily treatable. So it's, I think, I just talked about patient-client barriers. I think as clinicians, we also need to look at our own barriers. Why aren't we treating, if we've got someone in front of us going, doc or nurse, I'm ready for treatment, and you go, no, you're still using. Where is the barriers in that scenario? So, as I said, I think we're exceptionally lucky, and the rest of the world's looking at us at the moment because they are expensive drugs, but the decision has been made to make them available to everyone regardless of their degree of liver damage. And I think we're probably the only country in the world, or one of the only countries in the world, that actually has quite that liberal prescribing. So obviously after 12 weeks, if the virus is gone, it's gone. It's not going to be. We hear these urban myths from clients that it's, that they're told that it's incubating or it's hiding or it's in remission. It's gone. And that's the other thing as health professionals, we just need to make sure that the clients are well educated so that they don't have those, that they go with as much factual information about risk and about future risk and future reinfection as possible. So the secondary goals of treatment, obviously we can slow down or stop liver disease progression. For some of the clients who are highly fibrotic or cirrhotic, I think one of the principles of keeping them in care is making sure that they're still engaging with the tertiary sector, because anyone who's cirrhotic will need to have 6 monthly ultrasounds for the rest of their lives just to make sure that they don't have a hepatocellular carcinoma. The other big thing that I see with our clients is we do see improvements in quality of life. I've had clients come up to me afterwards and go, "Gary, I can get out of bed without using meth for the first time in 20 years. Or this is the first time I've ever achieved anything in my life, and I'm going on to do this TAFE course." That's not everyone, but there is a real sense of achievement. And I think there's a real sense that I've got rid of this alien that's been in me for the last 20 years, and I don't have to, every time I go to the dentist or the doctor, write down Hep C positive. There was a real internalised stigma, and we all see that in our client base. And obviously from a public health perspective, loss of infectivity. Okay, some of you may have seen a slide similar to this, but it usually ends at 2016. So this is taking the data out of who's been treated up to 2017. You can see from that very dark blue line from 1997 up to partially in 2014 and 15, that was the interferon ribavirin days. And some of the early stage directly acting antivirals towards the end, like telaprevir and boceprevir and sameprovir. But as you can see from the 1st of March 2016, it was almost exclusively directly acting antivirals, and in 2017, by the looks of things, there was no interferon used. But you can also see that we had this great level of excitement in 2016, and then the numbers came down in 2017. And I think you'll find that when the 2018 figures come out, you'll see the same sort of thing. We're seeing a decline, and I think there was a greater sense of excitement in our client base, and now it's becoming almost normalised, and it's, I'll get to that one of these days. I know it's there. I'll get the treatment eventually. This is also a slide that many people have seen, and it's the breakdown of who's treating hepatitis C. And as you can see in the early days, and it doesn't go back to, well, I suppose we only really need to go from March 2016. Mainly the hepatologists and the gastroenterologists who had a backlog of people waiting for these drugs. But over time, you can see from about March, June 2017, that sort of pattern of who was treating is basically stabilised off. So we know that the bulk of the treatment, even though it's not really definitive in saying physicians, general practitioners, other specialists, that's a bit murky. But we can see that general practitioners now are taking about a third of the treatment. The other problem with general practitioners, unfortunately, is we've got thousands of them, and often they've only got 2 or 3 clients each. So it's a matter of making them aware that there's treatment, getting them into the treatment process. I'm just waiting down the line for someone who has been in a GP's treatment for 10 or 20 years, and now that we know about hepatitis C being easily treated for the last 3.5, 4 years, someone who's being sat on in that clinic, getting a cancer, and going, why didn't you treat me? And I think once that happens, then the legal implications will give people the impetus to actually treat some of the clients. This is the last slide, and then I'll hand over to Mary for the next section. So you can see on a state-by-state basis from March, over the 2-year period from March 2016 to March 2018, this is the breakdown of how the states are going. Obviously, some of the smaller territories have very few, have much less per capita of population. But as you can see, we're about 24%, which is, I think we've got many other states ahead of us. So, but that doesn't really account for the fact that we've still got infections happening on a yearly basis. And it'll take a while before we treat so many and people who are still using will actually not be transmitting virus. Okay, hand over to Mary.
Thanks, Gary. We thought that because this was such, there was so much information in this presentation that it might be nice if we just operated as a bit of a tag team. So I'm just going to tell you a little bit about the treatment itself and some of the nuances around it, particularly in the substance using population. The slide that you can see is a summary of data that was presented recently in Brisbane by the Keogh Institute, national mapping of hepatitis C treatment, uptake, etc. One of the significant things, and I guess a lot of this goes to those remote and rural areas that might be listening in today, is that people that are least likely to uptake treatment are those from a lower socioeconomic status, have lower self-assessed health. They're participating much less in screening programs. They have a lower life expectancy. They have a higher incidence of preventable hospitalisations. So it's just a reflection, once again, that the people that really should be accessing and receiving treatment are the most that aren't likely to be doing so. So specifically from our perspective, people who inject drugs are a key population that need to be identified and treated in order for us to achieve the elimination goals. And the World Health Organization has a stance that they've taken on eliminating the incidence and the episodes of hepatitis C. In Australia, the goal is that we will have eradicated hepatitis C by 2030. And the way to achieve that is amongst our people who inject drug population. And a lot of those people, as you can see from this slide, tend to circulate within correctional facilities and are often people on OST. So there are some commonalities there. This is just a very simple breakdown of treatment that's currently available. And I wasn't going to spend a lot of time today talking to you about what treatment is currently available because it's so simple. It's so simple. And really, the two that you need to think about are the two top in this grid, and that's sibosuvir and valpatisvir, otherwise known as Epclusa, and glecaprevir and you know that other word that's underneath that? That's called Mavorite. So they're the two that are pangenotypic. So really, they're the two that most people are using at the moment. Elbasvir and grazoprevir, Zapatier, is indicated for people who may have renal insufficiency, but it is genotype specific, and softened lead is virtually not used any longer. These guidelines just need to be updated, and things are moving so quickly in terms of treatment. They just haven't been updated since September of last year. There is another player on the block called Vocivi, which is triple therapy. That's Sof, Vel, and what's the other one, Gary? Sof, Vel, and Voxoprevir. So it's a triple therapy, Vocivi, and that's available to people who have previously been exposed to either Sofenvel or Mavorite. But that's a whole other discussion that you would want to have if you were treating in the community. So just to let you know, or just to give you a sense of how really simple it is now to decide what treatment a patient might need. And usually it comes down to, what would you like to do? Take 1 tablet once a day for 12 weeks, or take 3 tablets once a day for 8 weeks. That's the decision that we need to make here. And that's the discussion that you're having with people. Now, Gary's already talked about the impact of treatment on outcomes, impact of successful treatment. There are many extrahepatic benefits at an individual level that I don't think people are cognizant of. And unfortunately, people will say, why should I have treatment? I have no symptoms. But what people don't understand or don't appreciate is that there is now very good data that backs up that people who treat, have an SVR, have much better outcomes in the long term, not just from a liver histology perspective, but in a whole range of other areas. For example, cardiovascularly, less strokes, less heart disease, also less renal disease. Hepatitis C is responsible for a number of cancers, not just hepatocellular cancers, but other tumours that may emerge. So there are good reasons to have treatment and to cure yourself. I think what people tend to forget is that living with hepatitis C puts a huge strain on an individual from an immunological perspective. We always tend to think of hepatitis C as a liver disease, and I've always argued it's more than that. It's an immunological disease. You are constantly struggling to clear this infection. Some people do it successfully in the first 6 to 12 months of infection. Many don't, and their bodies continue to struggle with that. So as a result of that, you have these extrahepatic manifestations and also the impact on quality of life. Starting to sound a little bit like a sermon, aren't I? The needle and syringe program survey that is conducted every couple of years, probably the most important thing to take out of this slide, and this coincides nicely with the data that Gary presented about the uptake of treatment in 2016, is that within the injecting drug use population, we were able to demonstrate that there was a decline in active infection. Now, the natural flow on from that is that less people within the injecting population with active infection is going to result in some stage down the line in less new infections. And that's the way that we are going to hopefully achieve that target by 2030. So there really is an important imperative for us to be actively treating people who inject drugs. How do people who are currently using drugs cope with treatment? There was always the statement that, compliance would be an issue, they'd be lost to follow-up, yada-da, there'd be interactions, etc., etc. There's been a number of trials done around the world. The ones that we are interested in now are the ones with Mavorite for 8 or 12 weeks. This is a retrospective analysis, but nevertheless, it demonstrates really good outcomes for people who are currently injecting who underwent treatment. And that is comparable to the cohort of people who are not injecting. A big difference in numbers here, but that sort of accounts for that discrepancy in the percentage overall, but still very good results, very good results. The other trial that was conducted, and here in Australia, there was a large cohort of clients that participated in this trial called Simplify. Adherence was around about 66% of the population who had equal to or above 90% adherence. We know that nobody is ever 100% adherent to anything. If you are somebody that's on medication, there will always be an episode where you will forget to take your meds. That doesn't seem to have a demonstrable effect on the outcome. However, it's not something that we would recommend that people seek to do. But at SVR12, which means a sustained virological response, 12 weeks after the end of treatment, 94% of this cohort of people who injected drugs had achieved SVR, which is fantastic when you consider that the rates are normally, as quoted in the trials, which I might add, the general trials, which I might add are only for the squeaky clean, 95 to 98%. So it was nice to see this stuff being demonstrated and being supported by evidence so that we were then able to argue for access to treatment for our clients who were injecting. This is just a bit more around the efficacy, and most people were quite candid in reporting they had ongoing injecting drug use whilst they were on treatment. And as far as we're aware, there are no adverse events associated with drug-drug interactions. That was perhaps not the case in some earlier medications that were available, but now it is not an issue. So it's obviously not a barrier. I'm just going to hand back over to Gary now and let Gary take up the next couple of sections.
Don't go too far away, Mary. I think you're about 3 slides away. Look, as I said before, I think, the average client who takes the medication, it'll work effectively. But we know our clients, they're not the average client, they're not the average patient. And I think it's great to actually take the chance while you've got someone in front of you to do a full medical psychosocial history and where they're at the moment, and also some really good workup for their current health. We know that our clients are really quite averse to coming in. Most of them have got white coat syndrome. Most of them don't want to see a doctor. Most of them will only go to emergency when they're really desperate for some care. So their preventative care is pretty low. So take the opportunity when you've got someone in front of you. It might be the only time in the last 10 years or potentially in the next 10 years that they get any form of medical care. The good thing is that with care coordination, and if you guys haven't got the resources to do care coordination, or I don't think we're going down case management. I think, we negotiate with the client on what they think they need to get through their 8 to 12 weeks and beyond. And we're quite happy to care coordinate with the clients if you guys haven't got the resources. The good thing is we know that a lot of our clients have mental health issues. This generation of DAA therapy, the drug-drug interactions are really, really good. We seldom see any red flags that we can that we go, sorry, can't treat you at the moment. So most people are treatable. We might need to change things around a bit. And I think the other thing I'd like to acknowledge, and I think I've said it earlier, is the stigma and the discrimination that our clients feel. If they're in front of you, it means that they're comfortable with you. And, I think if they're comfortable with you, they'll listen to you, and they'll listen to your candour and your advice. And that's the reason why our clients don't present, is that fear of someone discriminating against them again. It's also important to look at some of their comorbidities, and when you're doing a drug-drug interaction, make sure you put what they're taking into the drug, or as close as you can of what's available on the streets at the time. Bloodborne viruses, the big flag obviously there is hepatitis B. If someone has Hep B and Hep C, they love to live together and they keep each other in harmony. So if someone's Hep C is being cured, then their Hep B might flare. So in that case, that's straight to someone who knows what they're doing, infectious diseases or the hepatology team. So most people who've treated a client will know this very simple algorithm for measuring fibrosis, cirrhosis, and it's called the ARPRI. The other one that goes with it is the FIB4. The ARPRI is just uses the AST and the platelets to give you a figure. If it's over 7, then you've got a reasonable chance of fibrosis. If it's over 1, then you've got a reasonable chance of cirrhosis. But don't let that be an impediment in itself. If that's over the parameters, if it's over 1, you know that you've got lots of Fibroscans around. We'll talk about that in a tick. QuIHN's got one, Hepatitis Queensland's got one. Regionally, they're reasonably accessible as well. The good thing also with the FIB4 has the same sorts of biomarkers in there, but it also puts in age. And as we know, as we're growing older, we have our own degree of degeneration in our liver and fibrosis. So it sort of accounts for the age as well. The other thing is these tests are only about 75, 76% specific and specific. Sensitive and specific. And so look, if this is the only impediment to you putting someone on treatment, get a relationship with a hepatologist or a gastro, because it's all about the clinical picture. If someone's got platelets of 400,000 and they've got an albumin of 40, and their ARPRI's up, often you can talk through their coexisting medical condition, and the clinician will say, "Sure, happy to see them, but put them on treatment now." And then you at least you haven't missed that opportunity when the client's really passionate about starting treatment. I talked about Fibroscan. People probably weren't going, "Well, what's a Fibroscan?" I think most of the audience here today have seen a Fibroscan before, and I've got my lovely one up the front here that Mary and I take all over the countryside. So this will give a reading, a quantitative reading on how stiff someone's liver is, how much fibrosis bordering on cirrhosis there is, and this is a non-invasive. No one does, very few people do liver biopsies anymore, so this is a non-invasive way of looking at liver fibrosis. And as you can see there, we sort of we have figures for different disease processes, and I can't give you a reason why other disease processes have cut-offs for cirrhosis and fibrosis, but with hepatitis C, 12.5 is bordering on the cirrhotic for the client and above. And so that's one of two major obstacles for people treating is this person cirrhotic? And the other one is, do they have a drug-drug interaction? If you haven't seen this one, put it on your desktop. If you've got a smartphone, put it on your smartphone if you're going to be using it as a clinician. This will give you a green, it's all good, I can't see any interaction, orange, look there, be careful, monitor them, or a red, look, definitely don't use this medication. The other thing that they've just introduced to this database as well is it will actually, when you start getting interactions, it will give you alternatives that you could potentially use for that client, just as a way of getting them onto treatment.
Oh, yeah.
That's you.
Time for me. Okay, so I'm just going to talk a little bit now about, well, to summarise, if you like, we've talked about the figures and figures of treatment and how they're decreasing. We're not going to be on target to meet elimination by 2030. We've talked a bit about the medications and what's available and the simplicity of them. We've talked a little bit about some of the precursors to treatment, how to determine whether somebody is or isn't cirrhotic and whether you should be treating them within your service or referring them on. So basically, the other thing is, what you need to do is find these people. And the way to find them, I think, is to do an audit of your clinical records. When I've been conducting outreach into certain areas like mental health and alcohol and drug, the best thing I think to find people has been encouraging the staff to go through their caseload and to look at whether anybody has ever had a test for Hep C, if they've had an antibody positive test, if that's been progressed to an RNA test, etc. You can also look for specific risk factors in any of your clients, injecting drug use ever, tattoos, incarceration, people from culturally and linguistically diverse backgrounds, any baby boomers. Baby boomers tend to have had motor vehicle accidents, motorbike accidents and blood transfusions prior to 1990. Baby boomers like me might have had a miscarriage back in the 80s, gone to theatre and been topped up with a couple of bags of blood and had absolutely no idea that that had happened. There are so many possible scenarios. People who've had treatment overseas, medical and dental, and that's increasingly common these days too. Men who have sex with men, there's a higher proportion of hepatitis C amongst men who have unprotected sex with other men, or even just something as simple as elevated liver enzymes. I've had people that have been sat on by GPs for years and years and years and years that have had elevated liver enzymes. They've thought of every other possible excuse except the most obvious one, which is when this person was 16, they had 1 or 2 episodes of injecting drug use. The GP made the assumption that this guy was a nice guy. He would have never used drugs. By the time we got to see him, he was cirrhotic. So don't make assumptions about what you think you may or may not know about patients. I'm pretty sure this audience wouldn't do that, but I know that out there in some worlds that is definitely the case. So really it's about finding these people, because we've probably had the first wave of individuals. We had what they call warehoused people that were cirrhotic with extensive liver disease, and we waited until direct-acting antivirals came along. Once it arrived, we treated all of them. And then we had this initial kind of flush of people being excited about the fact that DAAs were available, and you saw the figures in 2016 where there was this big uptake of treatment. And then as time's gone on, things have petered off a little bit and it's no longer much of a priority for people. So what we're hoping to do today is to reinvigorate that. So how do you do that? You just test. Test if somebody's ever been exposed, and that's really simple. It's just an antibody test. If the person is antibody positive, you then need to know whether they're one of that 15 to 25% of the cohort that's ever been exposed to antibodies that have spontaneously cleared virus themselves. Some people do that. If they have not, then they're HCV, RNA, PCR positive, and that means they have chronic infection, and that means that they need to have treatment. These tests can all be ordered at the same time on the one pathology slip. You just order hepatitis serology, Hep C RNA, and I put Hep C RNA and or genotype. And if there's no RNA, they'll get back to you and say, we couldn't do a genotype because there's no RNA. Don't wait for subsequent visits, etc., etc. This can all happen there and then at that one visit. You've got your genotype, and then also you need full blood count, liver enzymes, their hepatitis B status. Find out whether in fact they've had immunisation in the past, because the number of people that we have unearthed that have got to this stage of their lives and not been vaccinated is extraordinary. So it's always a good opportunity to ensure that they're vaccinated. And that can all be done, like I said, in that one visit, so that by the time the person gets back for the next visit, you're ready to treat them. Like I said, treatment is very simple. There are a number of excellent resources that you can access in order to walk you through treatment. Probably the best one is the GISA guidelines, and you just log on www.giza.org, or alternatively ASHM have this document available for you to download. The document on the left is a what they call a fax back form. So that's for people who are new to treating an individual in the community, and it just asks you to complete a number of parameters which look at whether somebody has chronic Hep B, whether you think they're cirrhotic, whether you've checked their drug-drug interactions with their concomitant medications, etc. What you do is you then fax that off to a hepatologist in your local health service, and they will go through and they will advise whether they're happy for you to go ahead with treatment or whether you need to think about referring that person in to their clinic. Usually 24-hour turnaround. Hepatologists are very happy in most health services to comply with this. So there is that push for eliminating hepatitis C, and we know that we have the possibility of doing that by 2030. If we remain diligent in diagnosing and treating Hep C, we can do that, and we can all be a part of that. We are already on the world stage as the most progressive country for treatment of hepatitis C. Everybody looks to Australia and is absolutely amazed and in awe of the fact that anybody here has access to treatment. That's certainly not the case in other countries, and not just developing nations, in lots of EU and developed nations as well. Not everybody has that luxury, which we do. So Hepatitis Australia released a document in 2017 that addressed specifically eliminating viral hep, and that was in a background of those reduction in figures in that year and their concern about us not being able to maintain the momentum. And so they talked about some of the things that were required was an awareness, the availability of treatment amongst healthcare professionals and all healthcare professionals, safe spaces, empowering healthcare professionals to confidently test and diagnose, and also to feel comfortable about discussing treatment with an individual. Acceptance is paramount, reducing stigma and discrimination for an individual in their comfort with testing and treating, and also access, harm reduction, demand reduction, people who've been incarcerated and people in mental health facilities all need to be targeted for treatment if we're going to reach this target. I'm just going to hand over to Gary. Gary's just going to talk a little bit about some data that we've collected through QuiHN in the last 3 years or so, 2.5 years, about treatment.
Thanks, Mary. Some of this data that I'm going to present to you now is our program through the Communicable Diseases Unit has a evaluation component done through QUADRAC, which is the Queensland University School of Public Health, and we also, when we're testing clients, we often will ask them to participate and give the data. We've screened close to 1,000. I think it's 998 from the data that I've got here, of which we've now treated over 500 people. So some of the 500 that were treated obviously weren't positive, and that's a growing trend that we're actually seeing now. Is people who thought they were positive are coming back as either not exposed to the virus or just having antibodies. But I think that's as an important a test as an important a result for the client, knowing that they don't have it, as it would be to have it and to have treatment. You could see here we started in January 2016 just with some of the getting ready for DAAs, and we also had some on special access. But you can see if you put a line through from 2016 to now, there obviously has been a drop-off in the amount of people who've been presenting for screening for hepatitis C treatment. Some of the data which has come through, some of the themes that have been coming through about why people either didn't come forward for treatment or didn't progress onto treatment was the fact that this is a disease process that, for the most part, doesn't have any symptoms. With liver disease, with hepatitis C, often you'll only see an acute process happening at seroconversion or at end-stage liver disease. So in the middle, when people are reasonably healthy and compensating, there's no great priority to get treated. The other thing which was evident was that about a quarter of the participants still thought there was going to be some side effects. And I think there was that urban myth still out there from the interferon ribavirin days that, you know, we'd sold people this treatment that didn't have the efficacy we wanted but had all of the side effects. And I think there's still people who are not coming forward because of that. And as I said to you, that condition of trust that you guys have with your clients, the other reason was they didn't have a GP or a clinician that they felt confident in enough to go in and you know, most of our clients, they'll walk in and the GP will say, what do you want? You know, there won't be any holistic care. So, and they're used to getting that sort of treatment. So, as I said, the opportunity's there, seize it. So from a client, also the challenges, I think there's a little bit of overlap here. Clients' wariness and uncertainty re the treatment. Clients very wary about their prior relationships with clinicians. The need to travel off-site for pathology, and that's one of the biggest barriers I see, is that we have clients who are fixated about their veins, A, because they're going to be triggered if we use them, and they might have been off drugs for a couple of years. B, the stigma and shame of someone down at QML or Sullivan and Nicolaides actually going, what are those things in? Oh, okay. So, and I've had a number of clients from different places that will actually present for a workup for Hep C and they're given a pathology form and they've never gone back. So try and limit the amount of barriers that you put in front of the client. Try and do everything in-house as one consultation. We know that our clients also have a I want this done today mentality. We'll try and accommodate that as much as possible and then we'll get them onto treatment. And also the lingering belief that if I'm still using, no one's going to treat me. So we've had a number of campaigns, and this is the latest. We're doing an initiative to get people in for a $10 Coles-Meyer gift voucher to test. If they go on to treatment, we give them a $20 Coles-Meyer gift voucher. And if they complete treatment and come in for their SVR, we give them a $30 Coles-Meyer gift voucher. Yeah. So, and look, we've had a few other initiatives where we've given people incentives to bring in friends or to treat someone they know. The good thing about that from an epidemiological stance is that if we treat everyone within someone's injecting cohort, even if they are injecting, we haven't got any more infection. And we've got a sterile environment. So people presented with multiple issues for screening for hepatitis C. We could see that a lot of them were or are intravenous drug users, but some were also worried about recent incarceration. Some had some social and mental health needs. Some were in counselling, some were in rehab. We've had some great relationships with the rehab, but a word of advice from treating people in rehab. People are often keen to make change when they're in rehab, but give them the chance to get the drugs out of their system and to experience other things. And if they're still happy to be treated a month down the track, that's a great chance to treat them as well. We can see from this slide here, there's no great surprises. The drug that we saw most for our client using was methamphetamines, and followed by cannabis. And this was just a snapshot of what the clients disclosed to us at screening. So the blue bar is basically asking whether they had used any of these drugs in the last 4 weeks prior to the screening, and the red graph on top of that is if they've haven't used in the last 4 weeks, but they've used over that 4 week period. Sorry, beyond that 4 week period. And this is a great graph, but it basically just tells you we've treated 500 people. Okay. Okay. So what have we achieved so far? Well, if you take all of the clients that we've actually had come back for their sustained virological response or this is your all clear test, 97% of them have cleared the virus, which is consistent with what Mary was showing with some of the research in a drug using environment. These people want to be cured. They really want to do something about their health. So I think some of the perceptions we have about drug users are our own issues, not things that are actually happening for the client. They really want to be treated. Unfortunately, we've told the clients that there is such a high chance of treatment success. We have about 25% of clients who don't come back for that last. So we think they've finished their treatment, but we haven't got the evidence to say that they've actually cleared the virus. We've had 22 retreatments out of that 500, so we've had 12 reinfections, and I think it's important that we acknowledge that there are no caps on retreating. The government's quite happy to, if you ring up and say this man's got this virus, they'll keep supplying the drug. And I think it's important that those that keep getting reinfected, we A, just keep reinforcing the messages, and B, keep giving them the drug and getting them cleared. Over to you, Mary.
So that pretty well formally ends what we wanted to talk about. I just wanted to make you aware of some excellent resources that are available for you. ASHM have everything you need to know about treatment, etc. They also run some great webinars as well. GESA, which is the Gastroenterological Society of Australia. That's where those consensus guidelines came from, and no doubt they will be updating those fairly soon, again with the arrival of VASIVI. Hepatitis Australia has some great resources as well, and a lot of their stuff is around the advocacy that they're engaging in with federal and state governments, and also they keep abreast of developments in overseas areas. The Kirby and the Burnett are both excellent resources as well. The Burnett has just received a staggering amount of money from the Ramsay Foundation to conduct a project over the next couple of years called Eliminate C. And it's 4 pillars: health, promotion and education, workforce development. I can't remember a couple of the other pillars, but if you have time, log on and have a look. It's really very interesting. And there is also the Queensland Health Hepatitis C Treatment Progress Report, which is just available from Queensland Health's website. So I'm hoping that that's met the needs, or most of the needs of people. Were there any questions before we finish up?
Thank you,
Yes,
Mary.
Marie.
I'll just pass the microphone over to Marie.
Thank you for that. I just want to ask, you've had 22 people who are treatment resistant, right? So what pathway did you actually take, to retreat them again? Did you have to send the blood to Sydney?
Look, I mean, people do talk about resistance testing, but I'm not really sure what the benefit of that is, given the only thing we've got to retreat people with is Vasivi anyway. And there's nothing on the horizon other than Vasivi. So, I mean, other than it being a matter of, dare I say this, intellectual interest for a number of people, I don't know that there's any great benefit for the client or the clinician.
So
Does that make sense, Maria?
Yeah, I'm just a little bit conflicted with that.
Yep.
Because I think, as doctors, we are actually told, do this. But, I really don't have any experience when it comes to, treatment resistant, when we retreat them again. I must admit, we had two, but, I thought of, sending it, back to Prince Charles, and that's what they did. They actually sent the bloods to
Yeah.
Sydney.
And how did you find that helpful, Maria?
Oh, I wasn't there anymore, so they actually treated the patient.
With
Was that the other thing?
So-
We tried with Epclusa.
mm-hmm.
So I was going to say, if like somebody who doesn't know a huge amount about the new treatments, if it failed once, is there a chance that it could work a second time? Have you seen that happen?
What we've seen, not so much if it failed once, what we've seen are people who have had a shorter duration of the recommended treatment time, and before we had Vasivi, we actually retreated people with that same medication, and it subsequently worked. There's a whole lot of discussion around compliance, etc. But now, with the availability of Vasivi, I wouldn't do that. I would automatically treat with Vasivi. Yeah.
Put a lot into adherence and support.
I forgot to do our final slide, where it talks about we've still got a long way to go. Did I do that? No.
Do you want to quickly mention it before we get?
I get to sermonise. We've still got a long way to go to ensure that people are accessing and being treated. And I think as clinicians, we've all got a role to play, and we can be involved in eliminating Hep C. This is a wonderful opportunity. We can be a part of something that's historical. We can help to eliminate Hep C. We haven't seen a virus or an illness, a bug eliminated since, I think, smallpox. There is a unique opportunity for us to be able to provide access to diagnosis and treatment. Treatment with DAAs is effective and achievable in lots of different populations, including people who are substance users. It's not difficult, and I think even if there are some issues that are puzzling you or disturbing you, it is very, very easy for you to phone up and get some information. People are more than happy to talk to you and provide assistance. And there's a lot of support. And basically, at the end of the day, if you wanted to have a chat with somebody, we're very happy to talk to you. So give us a call. Sorry.
That's right. And it's a continuation of the previous question.
Yeah.
Of the 22, 12 were reinfected. What were the other 10?
Some were incarcerated.
Lost to follow up.
Yeah, there was a few that were lost to follow up, a few that were incarcerated and didn't, they were on treatment and then they were taken from the watch house to the prison.
And the pills got left behind.
Pills got left behind. I think there was 2 that had problems with refilling at the chemist, so that they went to go and get their next lot of pills and it wasn't there, and they got a bit huffy about it and didn't go back.
We've got one question online which I know the answer to, but I'll let you respond because it may also give you an opportunity to talk about the link worker that you've got as well. So somebody's asking, is treatment currently available for people that are incarcerated?
Oh my God, yes, there are. This is a subject that's near and dear to all of our hearts. Treating people in correctional facilities is absolutely a great way to work towards eliminating Hep C, and lots of facilities are doing it now. Woodford, Brisbane Women's, Arthur Gorrie, they're all doing it, and it is available. One of the nice things that we have recently initiated with QuiHN is a prisons liaison worker, and that person is particularly adept at targeting people who are entering correctional facilities and who are exiting correctional facilities. I have a client whom I worked up for treatment and was all ready to go, and he was incarcerated. So I can now use the prisons worker, Dorrit, to liaise with the prison, and they can start him on treatment. There is no need for any of that workup to be repeated. Likewise, if people come out of prison, it's not unusual for them to have commenced treatment, go to court and be released from court, and they can be lost only having taken half of their course of treatment. We're very good at tracking those people down and making sure that they finish their course of treatment as well. So it's about plugging up those little gaps. Yeah.
Thank you. Have we got any more questions, or is that it? No, I think that's it. So I'd like to say thank you to Gary and Mary for an excellent presentation, and hopefully we can clear hepatitis C by 2030, as you say.
Be great, wouldn't it?
Fabulous.
Yeah.
So we'd
Yeah.
like to thank Mary and Gary for
Thanks so much for listening.